The first question raised, I think that's to Dr. Dilip. It's the guidelines for removing the IV cannula when the patient is to be discharged home with IV antibiotics. That was one question. Guidelines for removing the IV cannula when the patient is to be discharged home with IV antibiotics. And related to that, when are we going to change the IV cannula in hospitalized patients? So over to Dilip.
Yeah, I've replied on WhatsApp.
Okay. Not all, everybody is not in WhatsApp.
Yes. In addition to the text reply, see the IV cannula used for preventing superficial thrombophlebitis, initially the guidelines used to say 72 to 96 hours, you need to change the peripheral catheter. However, subsequent meta-analysis have reviewed that even for 5 to 7 days, if there is no obvious signs of infection, you don't need to remove it. So a lot of it is based on the local hospital infection control policies and their groups, how they define it. But that said, the dictum is around 3 to 4 days where the peripheral cannulas are routinely replaced. With regard to home management of IV antibiotics, the right way is with an indwelling catheter that has a duration of use from anywhere from short stay to 7 to 14 days and all the way up to weeks, 4 to 6 weeks. So peripherally inserted central catheters frequently are used for this indication. In resource limited settings, the peripheral IV cannula can be used provided the same guidelines that we use for the inpatient setting are maintained. That's a go-between way to do this for outpatient antibiotics and not the preferred modality. Preferred modality is to use indwelling catheters such as PICC lines that is commonly used these days for longer duration. And any other comment, ma'am?
Yeah, if a patient is going to be on antibiotic for more than 10 to 14 days, PICC would be the best option because it's so painful and later they don't get veins. So PICC, but then requires a lot of training because most of the PICC are OPAT, outpatient antibiotic therapy. So there should be a dedicated team to handle that who is trained to prevent all the complications related to that. Otherwise, the peripheral line as a general rule is 3-day rule, but it can be extended if you don't get a vein and carefully observe daily.
One other question was about using CRP as a post-operative fever indicator. Is it a reliable marker after surgery?
No.
Regarding post-operative fever?
Short answer, no. Long answer.
Yeah, the same thing. It doesn't have much of a significance. Only thing is just a pointer. We can't rely too much on that.
Regarding this Vidal test, the thing is, at present there is an increase in enteric fever in Kerala. For the last 15 years, I think I hardly used to see any case of typhoid. But now, Vidal, especially in peripheral centers, is a very, very important test because the blood culture, it takes time. Patient comes and if the Vidal is positive and it is strongly positive, I don't think there is any harm in starting medicine for it. And most of the time, like blood culture when we send, out of 10, hardly one comes positive. So you should not just wipe off Vidal. We are also reading in the book, Vidal is useless, Vidal is useless. But Vidal, for practical points, it's a useful test, but it has to be interpreted properly.
The interpretation is the problem, sir. Like you definitely, there will be definitely good clinician who can take, analyze, and then otherwise, a Vidal of 1 is 80 is considered positive. But then many do that way. We have come across several patients who come and was told that they have typhoid. When we evaluate, it is something else. It could be TB, anything else. So I think it is widely misused by a test that we will have to accept. We should have an answer for a better test. As you said, the blood culture, it's costlier. As to do as an outpatient, I fully agree. But that is the gold standard. What is next? Then you have some serologies called Salmonella IgM test. Again, you can miss paratyphi, can pick up Salmonella typhi. It is a good test with better than Vidal definitely because it can become positive earlier and Vidal it's best used during the second week, beyond second week. Otherwise, 1:80 is often considered positive and even after multiple education, if you have a positive result of 1:80 and told as positive, Nobody ignores it, and they clinch that to the diagnosis. That's the fact which we have to accept. So I think Vidal has to go. We should have better tests. You can apply Vidal during the second week, but we should have a better test. Then only I can answer your question. We have better tests, but it's not widely available, and that's a fact. I agree.
Just comment about Ravi's talk. I enjoyed the talks and the mnemonics, W's, 7 W's. And the first point about you said early fever, non-infectious, 20% mortality. In that situation, you mentioned the last point, the malignant fever syndrome. So in the pediatric age group, we have got a little more importance of that because some of these entities were the anesthesia leading on to high fever, especially metabolic muscle disorders we encounter. Another situation is the basic temperature regulation problems, including the hypothalamus, temperature production, temperature dissipation mechanisms. Something wrong with the skin, sweat glands, and the controlling autonomic and the endocrinological. The sweat production mechanisms in the endocrinology, diabetes insipidus. Some of these kids have sweat production problems related to this thing. They're all entities which may occur in the early part, rare only. Then about Rajalakshmi, so again, a lot of important points. Why there was not much of examples you quoted were all respiratory. What about in the COVID scenario, we are getting many of the cases of the black fungus and mucormycosis and sinopulmonary part were not mentioned. Why is it due to because the Amrita, there was a lot of cases and a lot of surgery, a lot of complicated cases. In your institution again, we expect, but there was no examples of that mucormycosis part from the.
We had actually published data. We had a series of around 30 cases with a good outcome. That was the most heartening thing, like 80% had good outcome. So we had almost all were sinopulmonary orbital with some CNS involvement. And we worked as a team. So it was all post-COVID, majority from neighboring state of Tamil Nadu, and majority had used steroids. So the case that I have shown was pulmonary mucor, but majority were sinopulmonary or with or without orbital or CNS involvement.
One more thing, when the audience among the IMA members are average is here above 60. So youngsters in the IMA are not there. That's one thing. So my humble request is in the coming years, as far as possible, make use of the new vaccines are coming. All of the above 50 get vaccinated, pneumococcal vaccines, and as we know, the newer vaccines, safer vaccines are coming for the herpes also. The Shingrix vaccine is a new recombinant one, no need to worry, highly efficient, and costly definitely. There are 2 doses needed. You can take because the chances of these both herpes infections and the postherpetic neuralgia will be much high. We are all above 70. The percentage of these things are more than 50% of the chance of this. Even those who had chickenpox, those who had herpes also. So newer vaccines are coming that should be taken, influenza vaccine and the Shingrix vaccine, that's the newer one. And the pneumococcal vaccines, and of course influenza vaccine is also economical. All these vaccines you need to be taken at least as senior citizens. Okay.
Anyway, I'm in the middle of a real experts on the critical care side, on the infectious disease side. As a surgeon, I just have a question to you. Because whenever we do long time procedures, for example, esophagus or avipul and all, these patient goes to surgical ICU or critical care ICU. The next day or probably in 48 hours time, when we look at the blood values, even though there is no focus or no clinical evidence of any sepsis, we find that there is an alteration of, one is platelets are slightly coming down, and also the INR gets altered. Is it something to worry? Because as a surgeon, when we look at, there is not much of features to suggest the patient is going for a sepsis. But still, it's a bothersome one when we see such values. What is your thought process on it? Or
Thanks for the question. This has been studied. This is a very interesting field of research in the hematology realm, where hematology and critical care overlaps. So the studies had looked at occult versus overt DIC as markers and predictors for mortality in sepsis and SIRS. So what we typically study is INR. We look at the platelet count. We may look at fibrin degradation products, which are always elevated in these cases. So that is the part that our labs are capturing because we test these things commonly. In the research side, they would also test for protein C, protein S, and antithrombin 3 and thrombomodulin. So what they found out was that in a subset of patients that have early SIRS in complex surgeries, they may actually have a transient state of occult DIC which we are not capturing. We are only seeing just the tip of the iceberg because we are only testing the PT or the APTT and just catching that part of the coagulation cascade. In these patients, in the research part, when they were looking at antithrombin 3 and protein cyst, they found abnormalities. They found levels that were abnormal that indicated that these patients have an aberrancy in their entire coagulation cascade, making them procoagulant, by the way. So what we may be catching is this occult DIC part that many patients then transition through to either recovery, or 20 to 30% of them might actually go into the SIRS direction. So we are seeing a small part of the story. The whole story is there in the rest of the labs which we are not testing for. But the important part is that if they truly have occult DIC, there is a 20 to 30% mortality signal in these patients who then evolve to full-blown sepsis. In those patients, actually the DIC was the marker that they have a single organ dysfunction. So it was not respiratory or cardiac or renal. The single organ that was problematic was the coagulation system. So the coagulation cascade was the marker for their future sepsis in these cases. So definitely a known entity, but we are only testing a small segment. So we are seeing that part. So maybe as a surgeon, if you're seeing early thrombocytopenia or a coagulation abnormality, flag it as a single organ dysfunction potentially going to sepsis. Like you said, you don't have time to lose. So instead of waiting for the respiratory part, I think the residents can take it as a single organ dysfunction and flag it as a risk indicator.
I am reminded of Rajesh's case, the Pseudomonas pseudomyeli producing this milioidosis, and I think Rajalakshmi must have a comment because we all should be aware of this entity in the coming time. The flood, lot of susceptibility factor, and non-controlled diabetes and all. We should be more aware of this entity.
Milioidosis, previously we used to label as a very rare syndrome or once in a blue moon kind of stuff. But if you go into the rural areas, I basically work with many of these hospitals in the rural area. Go there, it's actually much common than what we thought. It's there. The only thing is that you don't have the good microbiology lab to pick and say that this is Burkholderia pseudomyeli. What happens is they label it as Pseudomonas group. They label it as a Pseudomonas group and just misidentified as a Pseudomonas. Unless you get into that automated mode or that kind of microbiology, many of these patients getting treated as a Pseudomonas. So that's how it goes. But if you have good microbiology, you can. But one thing is the clinical suspicion should be very strong. If the patient has an HbA1c of more than 10, presents with something like a tuberculosis or any occult abscess, septic arthritis, and for that matter, infective endocarditis. Even I had infective endocarditis with milioidosis, I had septic arthritis. So one thing is that clinical suspicion should be very strong, and the communication to the microbiology department from the clinician should be very prompt. We should actually tell them that there is a possibility that it could be milioid. So if these two things, if you suspect, for example, alcoholic or with the potential risk factors like diabetes, a cavitatory pneumonia, you have to early think. Otherwise, we may get misled with the microbiology. Even the microbiologists are not seeing the patient, so they're just looking into that. So the good communication between microbiology and the clinician is the first and foremost thing.
Sir, thank you for the excellent updates. especially excellent presentation by the speakers. My doubt is one regarding the collection of a sample for culture, urine or blood. How relevant it is when the patient comes to you after taking 2 or 3 antibiotics? What is the accuracy of the culture report, whether you can rely upon it? Second thing is to Dr. Dilip, because in his presentation about the inappropriateness of using antibiotics in certain conditions like malaria, dengue, viral fevers, and I saw that in that column you have mentioned dysentery. So do you think that dysentery is not related to bacteria, or is there any other explanation? Thank you.
Regarding the blood culture, so we did a study which showed that our blood culture bottles hardly get filled. That's a main problem. So how much ml are you supposed to take? Are you taking it rightly? We looked at, and the compliance was less than 50%, and then we retrained and it went to 70%. So adequate volume is the main thing. So if a patient comes after taking 2 to 3 days of oral antibiotic, still if he is running fever, please do. Because that antibiotic wouldn't have covered, but still you can pick up. And because blood culture is the most important tool if you are suspecting a sepsis or a bacteremic process. In case of meningitis also, after 1 shot you can take blood culture. So remember, and you can also do an audit that the volume matters. And if you cannot take 4 bottles, which has 5 ml each, please take at least 2 bottles, which is 8 to 9 ml each. So volume matters. So there are a lot of things that can go wrong with blood culture. That affects the yield. It is not that the antibiotic alone. If you look at the practices, you can definitely learn that you can improve. So if the patient is running fever, go ahead and do. There may be definitely a reduction in the culture yield, just like urine cultures after antibiotics. But that should not inhibit you. You should go ahead.
Sorry for the lack of clarity on that, doctor. I'll clarify that. One was related to the old villain that we were discussing, which is Vidal. People get that positive, label it as dysentery when it is not truly a dysentery. That's what I meant. That is one problem. The second problem is that because of the resistance patterns of, say, quinolone resistance, the typical formula is for dysentery would be like a quinolone plus a metronidazole combination, which is frequently inappropriate in that setting, because if it is indeed salmonella, you're better off doing the 1 gram azithromycin protocol in some of these patients rather than giving the quinolone plus metronidazole combination, which doesn't really serve the purpose in those cases. So these are the 2 reasons why I meant that dysentery could be a marker for an inappropriate choice.
I want to ask about this ferritin level. Should it be used routinely in all cases of fever?
No.
Especially now with the dengue, what we have found is that the serum ferritin level correlates very well with the prognosis, how the patient is going to behave.
Do we have data for that, sir? Because in any hepatitis, ferritin will go up. It is an acute inflammatory marker, so it depends on whether the patient has persistent cytopenia, and you are using as a marker for HLH. Otherwise, any hepatitis can cause increased ferritin. What is the number? What is the cutoff by which we can go up? Otherwise, it will be a costly test which is more often used and misused.
You see, in last 2 months, I have treated more than 200 cases of dengue fever admitted. So, and I'm trying to write a paper on it. Ferritin and SGOT, SGPT, they correlate very well. I can predict now when the patient gets admitted that what is going to happen to him. How many percentage will develop a severe thrombocytopenia and other things. It is correlating very well. Just I wanted to know.
Definitely.
What is your...
So usually if you have a transaminitis, that itself is a warning sign, like patient has abdominal pain. So do you need ferritin in addition to that LFT is the next question. If you have, but then if you have a correlation number which will help you to triage and make it as a dengue with warning signs or predictor, it will be good, but we need data. Otherwise, even transaminitis is a good enough marker to predict severity of dengue.
So most of them have answered. It's a straightforward question. So patient is coming in with an undifferentiated fever with a cardiovascular finding. The only thing was the outside echo was normal, and there was a delay in reconsidering the possibility of endocarditis at that point. Because it is easy to diagnose endocarditis if it presents in its museum fashion. But what happens in a busy setting, in a government setting where you have more than 80 admissions per day, most of them, some of them at least are branded as lepto. because they have total count high and acute kidney injury, and we had later things. So that is only the thing. So the skin changes of endocarditis, and likely diagnosis is endocarditis. Next slide. Next slide. So transesophageal echo was done, which showed a vegetation on the aortic valve, and blood culture gave beta hemorrhagic streptococci. Next slide. So infective endocarditis is often missed. So the main important thing in infective endocarditis is when a patient lands up with a problem, most of the time it is taken as the diagnosis, and we fail to identify that it is not the presenting diagnosis, it is the complication of the underlying endocarditis. The example is recurrent strokes and hemorrhagic strokes. When they land up here, we often attribute it to a stroke or a multiple strokes, and patients are put on aspirin, clopidogrel, and later they turn out to with shower of cardioemboli. So failure to identify or failure to differentiate the primary disease from the complication, that is one thing which is highlighting the importance of endocarditis. And in clinical setting, if fever partially responds to antibiotics and again recurs, one thing we have to keep in mind, there is a deep-seated collection or there is intermittent bacteremia. So this concept you can use in our daily practice to consider the possibility of the mechanism for persisting fevers. So that's all about that case, and thank you very much. So this is the case number 5. So as Sharik sir is waiting, I won't take much time. So this is Sutton's law. So we have to hunt where the treasure is located. Next slide. This is a 33-year-old male who is a diabetic who presented with fever of 1 month duration with intermittent chills and rigors. He had weight loss and low backache, pain on passing stools, and he had no other obvious clues, no flank tenderness, and he was being managed as urinary tract infection based on the urine routine findings on and off from different hospitals. So you can see the total count was high, and polymorph 87, high platelets, RBS uncontrolled, and alkaline phosphatase was again on the higher side, and all other routine works were normal, and urine culture and sensitivity suggestive of E. coli. So actually the next slide. So this looks like a UTI as per the urine routine, but the fever was not responding properly, and he was having on and off intermittent febrile episodes, and again rigor and chills occurring, reappearing later, and he was being managed and being evaluated for the possibility of urogenital tuberculosis. So why the fever is persisting? Is there any problem in what is the likely diagnosis in this patient based on the symptoms of perineal pain, pain on passing stools, and what is the duration of treatment if you give antibiotics? So we will go to Sharik sir's session. Thank you.